Yeah, that's a great question. By definition, conditional recommendations should serve as default positions that are subject to individualization, pending patients and family values, preference, and not as rigid mandates. The conditional nature of these recommendations really reflects the limited high quality evidence we have in pediatric VTE prevention. However, that said, the guideline panel did make an effort, a deliberate effort, to identify potential higher risk subgroups within each population who might benefit from the use of anticoagulant prophylaxis to the extent that the existing literature allows us to do so. And these subgroups are highlighted in the remarks that accompany each of these recommendations. So for implementation, we recommend that institutions should develop subpopulation-specific algorithms that should be informed by these guidelines remarks. For example, critically ill children with central lines and mechanical ventilation, or patients with leukemia receiving LS asparaginase who have central lines. And whenever there's a validated risk assessment model, such as the CHAT ICU that is for critically ill children, this type of risk assessment models can be integrated into the electronic medical records for automatic stratification. At the end of the day, these algorithms should define local thresholds, establish consultation triggers, and incorporate shared decision-making while allowing clinical override with appropriate documentation. And the documentation is really key here. It's very important to document why patients' management deviates from the conditional recommendation, because it allows proper review of outcomes and will help us build better evidence in the future. Yeah, so there are two key principles that needs to be considered. The first is understanding the difference between relative risk and absolute risk for VTE. While the presence of a central line dramatically increases the relative risk of VTE, the absolute risk remains relatively low in many pediatric populations. Therefore, that is why it's so important to be able to identify those higher risk subgroups or to perform better risk stratification within patient population, within a pediatric population. Now, the second key concept is that to recommend anticoagulant prophylaxis, you kind of need evidence that it works in preventing VTE with what we consider a favorable risk-benefit ratio. All anticoagulation has risk, and often the children who are at highest risk of thrombosis, they're also at higher risk of bleeding. So you can't consider the risk of VTE without also considering the risk of bleeding. So while we know that, over the last couple of decades, there have been like a 200-fold increase in hospital-acquired VTE, the guidelines conditionally recommend against routine prophylaxis in all populations because of these two risk factors. Remember, pediatric VTE differs fundamentally from adult disease in the sense that children do require multiple concurrent risk factors in order to develop a VTE. And it's those children with those multiple risk factors that appear to benefit from prophylaxis. So rather than viewing VTE as a universally preventable complication, we as clinicians need to focus on identifying the highest risk subsets of children and ensuring early recognition and treatment when VTE actually does occur. Yeah, so this comes back to my point about the difference between relative risk and absolute risk for VTE. Despite the dramatic increase in incidence, pediatric VTE remains a rare disease, which makes research kind of challenging. So sample size limitations require multi-institutional collaboration to achieve adequate statistical power to demonstrate benefit. but it also impacts the implementation. There's tremendous heterogeneity across in the pediatric population, across age groups, medical conditions, clinical settings. You have to take into consideration developmental hemostasis. That means that there's an age-dependent coagulation differences that cause different VTE and bleeding profiles that can vary significantly. Just think about neonates versus adolescents. And then finally, data standardization remains a challenge with inconsistent risk factor capture and outcomes definitions across studies. On the other hand, the guidelines can accelerate this research agenda and overall all pediatric VTE research agenda by identifying key knowledge gaps and setting research priorities. In fact, the panel in the guidelines identified research priorities within each PICO question, addressing the unique evidence gap for each of the populations that we provided recommendations for. And at the end of the guidelines, we've sort of emphasized two major key priorities, one of which was the development of validation of subgroup-specific VTE risk assessment models, and the other is the evaluation of safety and efficacy of risk-stratified anticoagulant prophylaxis strategies across different pediatric subgroups. I think that by establishing these consensus priorities and promoting a standardized data collection, the guidelines should help hopefully catalyze funding and collaboration moving forward. I think with appropriate documentation and description of clinical decision, like we were mentioning on the first question, making within the context of the guidelines, then the cohort data will be more interpretable and useful for advancing our knowledge in pediatric VTE prophylaxis.